good morning to the audience. I am Dr. Mohamed Sany bin Shoib, consultant anesthesiologist from Ampang Hospital, is your moderator for today's live workshop. I am taking this opportunity to thank Malaysian Special Interest Group of Regional Anesthesia, SIGRA, Under Academy of Medicine Malaysia, ASPEN Malaysia, Malaysia Medical Association, Department of Anaesthesia and Intensive Care Hospital Kuala Lumpur, Department of Anaesthesia and Intensive Care Gleneagles Hospital Medini Johor for the collaboration in organizing this live workshop webinar for the year 2020. The objective of this 2-hour workshop is to provide the anesthetists and other healthcare professionals with up-to-date and highly credible medical education with a live OT regional anesthesia demonstration and experience to the anesthetists to improve surgery and patient outcomes. All the anesthetists nationwide in both government and private sector would be able to participate in this workshop by invitation, and CPD points will be awarded accordingly. For today's session, we will be having list of speakers and facilitators from both Department of Anesthesiology Hospital Kuala Lumpur and Gleneagles Hospital Medini Johor. Several housekeeping announcements for the audience. There will be 2 lecture sessions for today, 1 live demo from Hospital Kuala Lumpur, and 1 pre-recorded demo video, and 1 live OT session from Gleneagles Hospital Medini. Feel free to drop in your questions and inquiry using live chat platform, which is available on your YouTube screen. During live session, we will prioritize and convey your questions by interacting with the facilitators in the OT, and some of the questions will be addressed towards the Q&A session at the end of today's program. For the remaining unaddressed questions, we will try to address at the end of the sessions. At the end of this workshop and during the panelist discussion, QR code will be displayed on the screen, and please scan the code using your MMA application on your smart devices to claim your 2 CPD points. In the era of pandemic COVID-19 and modern anesthesia, why regional anesthesia getting into popularity? Planned surgery are ground to a halt, and now we have to get them going again. Many more surgery could be safely performed under regional anesthesia or RA. So RA assists to increase theatre outputs significantly. Even outside of viral pandemic, there are abundant reasons for making RA as your first choice. Right now, there are pressing needs to increase cases turnover in OT. With reference to CPD points, video and online conferencing came of age now. Working from homes also becoming the new norms, and that's why online educational activity also becoming paramount important. So our topic for today, live RA workshop, is regional anesthesia for the chest. So there will be 2 facilitators from Hospital Kuala Lumpur and also 2 facilitators from Gleneagles Medini Hospital. So I will introduce the 2 facilitators and speakers for today. Dr. Azrin Muhammad Azidin. He's a consultant anesthesiologist in Department of Anaesthesia and Hospital Kuala Lumpur, and he's graduated with MBBS from University of Malaya and obtained a Master of Medicine in Anesthesiology from UKM. He's holding various portfolios as anesthetic coordinator for robotic surgery, renal transplant, and training for Masters in Anesthesia in Ministry of Health. In regional anesthesia, he is convener of Malaysian SIGRA, co-founder and committee member of Special Interest Group in RA. He's conducted international and national RA workshops in various capacities since 2008, with the recent faculty for Austra in Kochi, Japan, 2019. He's also a member in National Committee of RA and supervisor for subspecialty training program in regional anesthesia. He's also author and co-author for various papers and guidelines on anesthesia for robotic surgery, renal transplant, and various documents and studies on regional anesthesia. So I would like to introduce the second facilitators also, which is Dr. Amiruddin bin Mohamed Kamil. He is a currently consultant anesthesiologist in Department of Anesthesiology and Intensive Care Hospital Kuala Lumpur. He is holding European Diploma of Regional Anesthesia and obtained his Master of Medicine in Anesthesiology from National University of Malaysia and also MBBS from University of Malaya. He is involved in special interest group in RA and the Academy of Medicine Malaysia, and also members of European Society of Regional Anesthesia and Pain Therapy. His area of interest are regional anesthesia, anesthesia for robotic surgery, pediatric anesthesia, and usage of ultrasound in regional anesthesia and critical care. Currently, he is a director of Regional Anesthesia and Subspecialty Training Program in the Ministry of Health Malaysia, and also facilitators for several ultrasound-guided regional anesthesia nationwide and internationally. So, without further ado, I would like to call upon our first speaker for today, which is Dr. Azrin Mohamed Azidin, with his topic of lecture is anatomy and available block techniques for the chest wall. Welcome, Dr. Azrin. Thank you.
Thank you, Dr. Sany. Assalamualaikum and good day to all. First, I would like to thank Aspen Medical, College of Anesthesiologists, Academy of Medicine Malaysia, and also Dr. Melo for all the parties' help in organizing this event and make this a realization for our SIG. So today I'll be starting the session with anatomy and options. I think any talk on regional anesthesia techniques will not be complete without the discussion on the anatomy, and those are along the lines of today's topic. I will briefly highlight the essential points, the anatomical points for the options for the block, and I will also explain how and why I've divided the block options into central and peripheral, and I explain to you all why later, or also from the posterior and anterior approaches. So we shall start by acknowledging that epidural anesthesia has been the mainstay of therapy for various surgical procedures of the trunk. We also had other alternatives for surgeries of the chest. Initially, we had the paravertebral techniques, interpleural techniques, and also intercostal blocks. But studies have shown that all these alternatives gave variable results and not comparable at times to the gold standard, which is the epidural technique. But over the last 2 to 3 decades, the introduction of ultrasound has accelerated the search for more practical and safer approaches, and that also helped us revisit previously deemed difficult blocks, for example, thoracic and also paravertebral blocks. And we also have to acknowledge that what we know today regarding options of chest wall blocks originated from work intended initially for breast surgeries. And it was from 2011, Blanco described initially the PECS 1 block and the modified PECS 2 block in 2012. Fallado Perez described Brilma blocks. Blanco again described Serratus plain block in 2013. And Bilateral described Serratus intercostal facial plane block and also pecto intercostal facial plane block in 2014. The works that initially were done by them has expanded with further understanding of block mechanics. So we are here today basically to discuss and to I will try to highlight what are the important points that you need to know when you're considering blocks for chest wall procedures. So, as I said earlier, no talk on regional anesthesia is complete without discussion on the anatomy. So, I will like to briefly describe The innervation for chest wall is actually through the thoracic intercostal nerves, and mainly from the T2 to T6, and majority of them from the anterior rami of thoracic abdominal intercostal nerves, and they run anteriorly beneath the respective ribs between the innermost intercostal and also intercostal muscles. And as they run anteriorly, they gives an anterior branch and a lateral branch, and the lateral branch emerge through the serratus anterior plane and divide into the anterior and posterior divisions. So this is basically a majority of the bulk of the innervation of the chest wall, and this mainly from the ventral rami. And not to forget, there's also a dorsal rami that goes posteriorly and divides into the medial and the lateral branch. So as you can see in the diagram here, the spinal nerves, the thoracic spinal nerves comes out from the intervertebral foramen, and it goes, divides into a dorsal rami and ventral rami. The dorsal rami goes posteriorly and divides into the medial and the lateral branch. The ventral rami goes anteriorly and gives off the lateral branch at around the mid-axillary line, and continues as the anterior cutaneous branch, divide into the branches parasternal region. The lateral branch divides into the anterior and posterior divisions. So this is another schematic, clearer illustration looking at the axial cut of the chest wall. So again, it is the same. So it is the same. Ventral branch continues anteriorly, and the dorsal branch goes and divides into the medial and lateral branches. The anterior branch comes out. The ventral rami goes out anteriorly along innermost and internal intercostal, divides into the anterior and lateral branch, and lateral branches divides into the anterior and posterior divisions. The anterior cutaneous branch continues anteriorly and comes out from the parasternal area and divides into its terminal branches. I'll be using more of this illustration during the explanation of the different types of blocks. Okay, so I divide the ultrasound-guided blocks of the chest wall into central techniques and also the peripheral or the interfacial approaches, and also acknowledging one, which is the erector spinae block, which is peripheral in approach but central in effect. So the central techniques can be divided into the thoracic epidural and also the thoracic paravertebral blocks, while the peripheral interfacial approaches can be divided into approaches that blocks the lateral branches and also those that blocks the anterior branches. The approaches that blocks the lateral branches will be the Brilma, the serratus plane, the serratus intercostal facial plane, and also the PECS 2 and rhomboid intercostal subserratus block. Whereas the approaches that blocks the anterior branches are the pecto intercostal facial plane block, transversus thoracis block, and also the parasternal PECS. And an approach that blocks both the branches will be the erector spinae plane block. So centrally, the central techniques, this is where you would deposit your local anesthetics. Okay, thoracic epidural, the thoracic paravertebral technique, and this is where you deposit your local for erector spinae plane block. And all these approaches actually provides anesthesia and analgesia to the whole hemithorax. So basically, the locals that we deposit for these three techniques have the potential to block the whole hemithorax and provides block of both the lateral and anterior branches. As for the peripheral or interfacial approaches, we have approaches that blocks the lateral branches, which is the Brilma block, where you block at the mid-axillary line. Serratus plane block, Serratus intercostal facial block, and the PECS2 and the rhomboid intercostal subserratus block. And what I've highlighted on the diagram are the injection points for those blocks, and what the blocks provides denervation of the lateral branches and covers the area roughly around from the mid-clavicular line anteriorly to roughly around the mid-scapular region posteriorly. And you also have techniques that blocks the anterior branches, and those are pecto-intercostal facial blocks, the transversus thoracis plane blocks, and the parasternal PECS. And this actually only covers a small area over the anterior side of the chest. So, in summary, we have multiple options. We just have to know what is required. And evidence for interfacial plane blocks remains encouraging. We have so far high quality evidence for PECS block in breast surgeries. We have moderate to high quality evidence for serratus plane block in thoracic surgeries. And there's also moderate quality evidence for erector spinae plane blocks in providing post-operative pain relief. And at the moment, the evidence are only limited to proven immediate perioperative benefits. There have been studies that shows that there's improved pain scores up to 12 to 24 hours, and also benefit in terms of reduction in 24 hours opioid requirements, and also significant reduction in post-operative nausea vomiting rates. And there are also studies showing that these interfacial or peripheral techniques are non-inferior versus the central techniques. So further sharing of experience and research into the long-term benefits remain an area where future emphasis should be focused on. So I hope that I've managed to impart to you the essential points that is required for you to understand the blocks better, so that you can actually perform the blocks successfully in the future. Thank you very much.
Thank you very much, Dr. Azrin, for a very informative lecture. We will proceed with the next session, which is live demo 1 from Operating Theatre, Hospital Kuala Lumpur, with the posterior approach of chest wall block. So I think we will get live transmission from Operating Theatre.
Assalamualaikum and very good morning. Thanks, Dr. Sany. Hello, everyone. I'm Dr. Amir from Hospital Kuala Lumpur. Following Dr. Azrin's lecture on the analgesia of the chest wall, next I'm going to perform the erector spinae plane block. The erector spinae plane block is actually an interfacial plane block. First, erector spinae plane block description is by Ferrero et al. In his paper 2016. Since then, erector spinae plane block has gained wide popularity and become a hot topic in regional anesthesia. Erector spinae plane block is actually a block that you inject a large volume of local anesthetic in between the erector spinae muscle and the tip of transverse process. after the injection of the large volume of local anesthetic, we found that the spread of the local anesthetic first laterally blocked the multiple levels of intercostal spaces. It also blocks the dorsal and ventral rami, as well as the rami communicantis. And the spread also blocks multiple levels of paravertebral space, and in contrast study, radio contrast study showed that the LA or the contrast study able to spread into the neuroforamina and also epidural spaces. So as you can see that one injection of erectospinae plane block can give rise to multiple level of blockade of the vertebral level. So I will proceed with the performance of the erectospinae plane block. The patient's position during erectospinae plane block is up to the preference of the operators. Today, I prefer the patient in the sitting position. You can also do in a lateral position and as well as in prone position, as long as you can access the patient's back. The arrangement of the block equipments should be arranged in a ergonomics manner, where the ultrasound machine and the operators should be in a straight line so that you maintain the ergonomics of the procedure. So highlighting a bit on the anatomy of the erectospinae muscle. Erectospinae muscles is a paraspinal muscles that run from the occipital area to the sacral area. It is not only a muscle, a single muscle, but it actually comprises of a complex of 3 muscles and also tendon that holds the vertebra into a straight line. So our aim is to inject the local anesthetic in between the erectospinae muscle and the tip of transverse process. The selection of probe, it depends on the depth of the erectospinae plane. If you think the depth of the erectospinae plane is more than 5 cm, you should select a low frequency curve probe. But if it's less than within 5 centimeter, I prefer to use a high frequency linear probe. So in this patient, the indication of erectospinae plane block depends on the understanding of the incision of the surgery and the ability of the erectospinae plane block to block the dermatomes that involve in the surgery. So we have a patient here who is undergoing for right mastectomy. So the incision of mastectomy is at the nipple line, which correspond to the about T4 dermatome layers. And I think the mobilization of the breast tissue will at least from T2 to T6. So I'm going to aim the injection at the T4 tip of transverse process. So let's proceed with the block manners. This is the high frequency linear probe. The probe orientation, I will orientate the probe carefully to be at the markers. So first, I am going to identify the T4 transverse process by calculating or counting the ribs. Okay, that's the you can see the hypoechoic line and the anechoic structure. That signifies the first rib. Next, in the middle of the screen is the second rib. And that's the third rib. And that's the fourth rib at the center of the screen. Can you appreciate that the ribs appearance, very hyperechoic line, followed by anechoic image below that. And please note that the proximity of the pleura in relation to the ribs. If you watch carefully, you can see the sliding of the pleura during respiration. So my target, I will move my probe medially and keeping the fourth ribs in view, trying to identify the tip of transverse process. So as I move the probe medially, you can see that the appearance of the pleura becoming less, less distinct. The echogenicity of the pleura become less distinct. And if you can appreciate, there's a bit of hum appearance of the from transition from the ribs into the costotransverse joint. So I will move my probe slightly to the medial and trying to get the tip of transverse process. Okay, now I purposely move my probe towards midline, trying to visualize the lamina. Okay. That's the flat line of the lamina appearance. So I'm coming back to the tip of transverse process. Okay. The muscle layers above the transverse process, there are three muscle layers, the trapezius, the rhomboid, and the erector spinae muscle. So,
can you show us, Amir, where is the trapezius, rhomboids, and erector spinae?
I need my assistant to point. Okay.
Yeah, for the benefit of audience, there are three layers, important anatomical structures to be identified prior injection.
Okay, the pointer now is at the trapezius. Next is the rhomboid, and the deepest layer is the erector spinae muscle. So now we are ready for the block. First, I'm going to inject from cephalocaudal manner. You can also inject from the caudate, but I prefer to inject from cephalate.
So you are injecting lignocaine now?
Yes, I'm injecting the local anesthetic now. So my needle will come from the marker side of the screen because I'm injecting from the cephalate.
This is in-plane approach, right?
Yeah, this is in-plane approach.
You are in the rhomboids now, I believe?
Yes, I mean at the trapezius.
Trapezius, okay.
So if in occasion where you lose the anatomical, the sonoanatomy, you can always trace back from the ribs and slide your probe medially and to trace the transverse process. Can I have a bit more gel?
May I know what is the depth of thrombus process from the skin now? Any idea?
That's around 1.5 cm. Can you pass me the block needle?
So this helps to determine what type and what is the length of needle you should use, right?
Yes.
By measuring
So,
the distance.
I prefer, although the length is, I mean the depth of the plane block, the plane of the injection about 1.5 cm, I prefer to use a longer needle so that I have a larger room to play around if I need to adjust my needle position.
Sure.
So I prefer to inject, or the point of my entry slightly far away from the edge of the probe so that I have also a bit of room to adjust my probe around.
May I know what is the length of needle selection?
This is 80 mm needle.
Okay. Yeah, we can see the needle tracking now.
Okay, I've already touched the surface of the transverse process. I can feel the grittiness of the transverse process. So now I will ask my assistant to inject some volume.
Are you routinely do hydrodissection prior to injection to determine the tips of your needle?
Not routinely, but in case in a deeper structure, I will ask for hydrodissection instead of active local anesthetic. So the local anesthetic today, I'm using 0.375% narrow pin, 20 mils.
Okay.
So can you inject a bit more, Fathil?
So if the needle tracking embolization is good, usually
So-
no need to do hydrodissection, right?
Yeah, so this looks good to me.
Yes.
Can see the spread, capillate and caudate as well. So, yeah. So I will proceed with the injection of the all the 20 mils volume of local anesthetic.
So Dr. Amir, is it a must to see the contiguous spread of the local anesthetic to adjacent ribs, adjacent thrombus process? Can you visualize it regularly?
That's the proof that you are in the correct plane. So if you can see just a lumping of local anesthetic volume in one side, at one side, so probably you need to adjust
Maybe in the
your
muscle,
needle.
right? Maybe in the muscle.
Yes. Okay. Okay. The other things that I always look is the pumping effect of the local anesthetic. Okay. Example, I have a bit more volume. Okay. Fazan, can you inject? Okay. Okay. Can you appreciate that the space become bigger as you stop the injection? The space collapse. So this shows that you are in the correct plane.
That's the pumping effect, yeah?
Yeah. So I think we have finished the. You wanna supplement a bit more? Okay. So I think we give a bit more of volume to just demonstrate. So I think volume that we can give for erector spinal plane block is about 20 to 30 mils. Okay, so we play around with a slightly more volume. Okay, Fathil, can you inject? Okay, can you appreciate that? Okay, stop injection, and the space collapse. Okay, so I think that concludes the injection, the erector spinal plane block.
So if you plan for catheter, is it at the same site also, is it?
Okay, if I plan for catheter insertion, I will inject, after I open up the space, after I open up the space, I will insert the catheter. I prefer Fajung E-CAT catheter because of its stiffer compared to the other catheters. That's my preference, but you can actually use other catheters as well.
Okay.
So, can I have a gauze? In some operators found it difficult to actually, during paramedian sagittal scanning, it's actually difficult to trace the true tip of transverse process. What you can do is actually, after identification of the level, let's say you opt for T4 transverse process, what you can do is you can do a paramedian transverse scanning.
Okay.
So you start from medial. Okay, I orientate the probe for you. Okay, the markers on the screen is the medial or midline, and I start from midline. That's the spinous process, and as I move the probe laterally, you can see the tip of the transverse process. If you can see, can you show that hypoechoic structure about 2 o'clock? Yeah, slightly above. Yeah, that's that one. That's the injection of my local anesthetic earlier. I've injected a bit of bubble inside, so it appears white there.
Okay.
But can you see the tip of transverse process? And on top of the transverse process is the erector spinae muscle. So the needle, it can come from lateral to medial. Any more questions, Dr. Sany?
I think for the time being, I think it's okay. Maybe if any question, we address further during the panel discussion.
So I just want to add a bit more.
Yeah.
As you can see, erector spinae plane block is much further away from the pleura.
Yes.
If you can show the pleura. Yes. So it's quite safe, and the effect of erector spinae plane block, I mean, a lot of evidence has said it also blocks almost equal to paravertebral block. So people has been calling the erector spinae plane block as a new paravertebral block. So now everybody can do the paravertebral block. I mean, no need to worry about pleural puncture if you do it properly.
Actually, just to add, I think if you're looking at this image, you can actually see this is the transverse process. That's the bubble just now, erector spinae muscle. That's the local anesthetic. That's the pleura, and this is the paravertebral space. Okay, you can actually go in here, and the paravertebral space is roughly around here. So that is one of the mechanisms postulated why erector spinae plane block works as well as a paravertebral block, because of the local anesthetic seeping through the spaces, yeah, and goes through this space and actually blocks the paravertebral area as well. So I think with this image you can actually appreciate the close proximity of erector spinae block site and the paravertebral space. So this is just one to be highlighted.
Okay, I have one technical question. So there is some literature stated you can inject either superficial to erector spinae, I mean between erector spinae and rhomboids, or deep to erector spinae between erector spinae and thrombus process. Any pro and cons in terms of coverage? I mean, of analgesia?
The outcome of superficial and deep injection of erector spinae plain block is actually the same. But my preference is to inject at deep erector spinae muscle because I have a clear target on top of the tip of transverse process.
I see, okay.
The other thing is that if your needle tip is going towards the transverse process, you actually have a safety mechanism of knowing where you are, because if you are hitting a bone, then you know you have to stop, rather than you are hitting a fascia and you still have the potential to advance further. So you don't have that safety mechanism there. And I think at the moment, regarding the question about ESP1 or ESP2, that was, I think, initially one of the earlier studies. All the other studies subsequent to that has always mentioned ESP block as the deep technique. Yes, yeah, the ESP2, the initially ESP2 variant. So I think if you refer to all the other studies subsequent to that, it means that it is the deeper version of the ESP.
Okay. Another question about the safety aspect is other than pleural identification, any other vascular structure that warrants you to activate color or Doppler prior to injections that area, I mean, of interest in terms and try to avoid in this area?
Actually, one has to be careful. The branches from the dorsal spinal artery, the muscular branches, actually it runs through from ventral into the dorsal muscles, the paraspinal muscles. It's good practice to always check for vascular signal, actually. So I didn't do that. But once, during your scanning, if you can identify a pulsating structure, you have to confirm with color or Doppler.
Okay. I think that's conclude the session in OT.
Thank you, Dr. Sany.
Okay, thank you very much, Dr. Amir and Dr. Azrin, for facilitating the live demo. Thank you very much.
Thank you again.
Thank you, Sany.
We will proceed with the third sessions, okay, with the lectures from Dr. Shahridan Muhammad Fathil. So I will now introduce two facilitators from Gleneagles Medini Johor hospitals. Okay, first is a speaker for today, Shahridan bin Muhammad Fathil. He obtained MBBS from University of Malaya in 1996 and obtained FRCA in 2003. And he's a member of the College of Anesthesiologists and Malaysian Society of Anesthesiologists since 2009. Current appointment, he's a consultant anesthesiologist at Gleneagles Medini Hospitals. And he's holding the chairman of Medical and Dental Advisory Committee there, and also clinical advisor for intensive care unit in HDU and emergency department. At the moment, he's an executive committee, a member of the Society of Emergency and Critical Sonography of Malaysia, WINFOCUS, and also executive committee member for College Anesthesiologists. He's also a board of directors of Oceanic Society of Regional Anesthesia and Pain Medicine. And his area of interest is peripheral nerve blocks and perioperative point of care ultrasounds. Then he had several publications also, nationwide, nationally, and also international publications. So I will introduce the second facilitator also, Dr. Mafeitzeral Mamat. He's also in Gleneagles Medini Hospital. His special interest is cardiothoracic anesthesia, transthoracic and transesophageal echocardiography, ultrasound-guided and nerve stimulator regional anesthesia, advanced life support and trauma, and also high fidelity simulation. He's currently is the head of department and consultant anesthesiologist in Gleneagles Medini Iskandar Putri Johor, and he's also a fellow of anesthesia and pain medicine from Royal Perth, Australia, Western Australia. So, without further ado, I would like to hand over the platform to Dr. Shahridan for him to deliver lecture of enhanced recovery strategies in breast surgery.
Okay, Assalamualaikum and very good morning, viewers. Welcome to Gleneagles Medini Hospital, Johor. I'm Shahridan Fathil. I'll be delivering the second lecture of today's webinar, titled Enhanced Recovery Strategies in Breast Surgery. Slide. This is the hospital that I'm working in. It's a small 200-odd bedded multi-specialty with significant critical care load. We are fortunate enough to have some of the surgeons who are pushing the ERAS agenda. So we have been working with them to fine-tune our techniques. The SIGRA is one of the special interest group under the College of Anesthesiologists, Academy of Medicine, Malaysia. As far as disclosure, I will be receiving a small amount of honorarium from Aspen for delivering this talk. Enhanced recovery has actually developed from just an initial quality improvement initiative until it has now become a movement. There have been establishment of ERAS societies throughout the world. In this part of the world, one of the leading hospitals that is doing or advocating ERAS is actually Tan Tock Seng Hospital in Singapore. Let's see how it all started. This was one of the earlier publications in 1994, fast-track recovery of coronary bypass patient. So this idea that patients can be extubated early in the post-operative period is where it all started. This was a publication by Kalat in 1995, Lancet, also looking at recovery after lap colonic surgery with epidural, analgesia, with early oral nutrition and mobilization. This was one of the first documentation of non-cardiac surgery with ERAS. And this is a 1999 BGS publication, hospital stay of 2 days after open sigmoidectomy with multimodal rehab program. So where are we today? This was, I got this from a JAMA Surgery March 27 publication to illustrate when in the late 90s, after the concept has gained momentum, there were 5 institutes from Edinburgh, Karolinska, Copenhagen, Northern Norway, and Maastricht, who got together and established the first original enhanced recovery after surgery study group in 2001. So where we are today, actually, it is a multimodal concept to ensure that patients do recover quicker, but from the anesthesia point of view, a lot of emphasis, at least before, was given to epidural, to the mid-thoracic epidural. This is particularly pertinent to colorectal or major gastrointestinal surgery, and I would like to take some material from this publication in 2009, a consensus review of optimal perioperative care in colorectal surgery. There's a long list of consensus guidelines from pre-admission counseling to bowel prep to fasting, right up to early mobilization, as well as nutritional care post-operatively. But in this particular consensus, emphasis have been given to the prevention of post-operative illness with mid-thoracic epidural analgesia, as well as post-operative pain, again with continuous epidural mid-thoracic, with low-dose mixture of local anesthetic and opioid. So this is the flow chart from pre-admission right up to post-operatively, and you could see in the post-operative, in the intraoperative period, there's emphasis on minimal invasive surgery, But from anesthesia point of view, there's a lot of emphasis here on regional analgesia, opioid sparing techniques, balance fluids, as well as temperature control. So why are we all doing this? I mean, as far as evidence is concerned, I'm just quoting this article. Basically, with ERAS, it has actually been proven to reduce length of stay, and after major elective colorectal surgery, without compromising patient safety. So the length of stay has significantly actually been reduced when patients come in for major colorectal surgery and they are actually put on the ERAS program. There have been, apart from colorectal, the concept of ERAS has also been applied to other surgeries. This was this was a 2017 JAMA publication, and you could see that there have been various publications, including anesthesia protocols, and in fact, the one below, the hip and knee replacement, as well as thoracic non-cardiac surgery, have actually been published, and it's available in the ERAS website. What about breast? With regards to ERAS document on breast surgery, there's only one published so far. This is actually a poster for a 2018 ERAS USA conference. The authors of this paper were looking at implementing some of the concepts, for example, using scopolamine patches to prevent post-operative nausea, vomiting, to optimize pain control using celecoxib as well as gabapentin. Intraoperatively, they were given antiemetics as well as PECS blocks. With regards to results, the pain immediately after surgery was significantly lower in the ERAS group compared to the non-ERAS group. But for 24 hours until 1 week post-surgery, the pain levels were not significantly different between the groups. With regards to nausea emitting, there was significant difference between the ERAS and the post-ERAS. The ERAS group tend to do better. Okay, this is one interesting article. There were only a few handful articles. I'm going to pick only two in this lecture. What this group of authors did was actually to recruit patients and compare it pre-ERAS and post-ERAS pathway. In the ERAS pathway, what they did was actually administer preoperative acetaminophen, paracetamol, gabapentin, scopolamine, as well as regional anesthesia, either a PECS blocks or paravertebral blocks, and intraoperative dexamethasone and ondansetron. And what they found out was that the implementation of the ERAS pathway for the skin-sparing mastectomy with reconstruction that incorporates regional anesthesia is feasible in a 23-hour hospital, and patients with ERAS pathway had improved postoperative analgesia and reduced postoperative nausea, vomiting. So in terms of the technique, I'm just going to concentrate on the intraoperative strategies that recommend the use of TIVA, minimize opioids, regional anesthesia. Patients either had a PECS2 or a paravertebral block, and intraoperative or perioperative antiemetics, dexamethasone and ondansetron, normal volemia, as well as normothermia. And you could see that in this particular, I won't go into great detail, but from the slides you could see that there is significant difference in terms of utilization of the strategies between the which is about 276 compared to the ERAS group 96. So in the ERAS groups, they are using more preoperative drugs as well as nerve blocks, TIVA, as well as antiemetics. Let's just go to the results. You could see from the opioid consumption, the ERAS groups, patients in the ERAS group use significantly less post-operative opioids, as well as the incidence of nausea or vomiting is much less in the ERAS group. So the authors concluded that actually the ERAS strategy or pathway does actually improve post-op pain as well as post-op nausea and vomiting. This was actually a systematic review, but the authors did mention that actually the studies that were included, there were only 9 studies that they managed to include, were actually of poor quality, most of them case series or case reports, and none of them actually randomized control trials. But also they found out that they conclude that the pathways, reduced opioid use, as well as length of stay following this is breast reconstruction surgeries without increasing complication rates. If you ask whether which one is better between PECS as well as thoracic paravertebral for mastectomy, there's this particular study comparing the two and they found out as far as acute pain, the PECS 2 block provided superior perioperative analgesia compared to paravertebral block. Okay, let's recap what we've actually said. In terms of strategies, what actually works, what actually improves patients' pain control, as well as reduce nausea vomiting, TIVA, total intravenous anesthesia, of trying to use minimal opioids or no opioids at all, paravertebral blocks or PECS blocks. As far as evidence is concerned, PECS blocks seems to be better in terms of acute pain. Intraoperative or perioperative antiemetics, dexamethasone, as well as one of the 5-HT3 antagonists. Normal volemia, so ensuring that patients are not dehydrated as well as not overhydrated. And another important thing is normothermia, ensuring that patients are normothermic intraoperatively as well as when they come out from surgery. So again, if I like to conclude, this is what we should do as far as to improve our patient in major breast surgeries. Thank you very much. Welcome viewers to our operating theatre. Dr. Mafis, my colleague, is preparing to perform a Serratus plain block, a case where we was listed as it was emergency case, rib fractures with a clavicular fracture. So it was listed for a clavicular open reduction and internal fixation, but we counseled the patient for Serratus plain block to improve pain control so that it's much easier for us to actually extubate him so that he is quite comfortable without having any respiratory embarrassment. So in the meantime, while Dr. Mafis is preparing to do this live, we have actually prepared a pre-recorded PECS 2 block, which we have performed 2 weeks back, so that we could share with you this, the performance of actual PECS block. And once we finish with that, we will bring you back to our operating theatre to view a live demonstration of the Serratus plain block. Assalamualaikum and a very good morning to all the viewers. I'm Dr. Shahridan. I'll be explaining some of the principles that we use for enhanced recovery for breast surgery. Okay, patient is now under GA, and later my colleague Dr. Mafeitzeral will perform, demonstrate on how to do a PECS 2 block. Okay, so one of the principles is, of course, we want to keep patient normothermic. We are using a forced air warming blanket with a proper blanket, okay, to keep the patient normothermic throughout the procedure. We are using total intravenous anesthesia, not gas. Of course, we are using a target control infusion pump with propofol. Keep the patient well hydrated. Of course, normal volemia, we're not going to overhydrate them. We are using also BIS, which is a bispectral index. Of course, this BIS is a bit low. We are trying to increase the BIS a bit to more, near 40 number. So these are the principles that we use. We hope to block the patient, and with a successful block, we would probably not need to use any opioids. So in the hope that patient wakes up in a more, I would say, favorable emergence profile. I think that's about it for me. I will hand over to Dr. Mafeitzeral, who will demonstrate, describe the block and demonstrate the performance of the PECS 2 block. Thank you.
Okay, hi. So what we're doing today, we're going to do the facial plain block of the chest wall. So as to this surgery, will be mastectomy. So what we will be demonstrating is PECS 1 and PECS 2. So I will go through in the sense of we will look at the initial scout scan of where layers that we want to insert our local anesthetic, the level for PECS 1 and PECS 2, and perhaps maybe show where the, if we are to do for, Serratus anterior block is also an option here. But I think before we perform this, I think it is very important to ensure that the patient is okay. Always have your eye on the screen and listening to the hemodynamics of the patient. At the same time, in terms of performing this, is the ergonomics. It's very important. The screen in front of you, my placement, my needle later, as you can see how I will demonstrate it here. All right, okay. So let's, can I have the ini please? Minta gel sikit. So we have the gel, and so we'll start off here, and what we will be looking at in the screen here, initially the clavicle and mid-clavicular line, and place your probe as how you would do your infraclavicular block from the clavicle. So as you can see, initially will be the vessels that would be your guide, will be your axillary artery and vein, and immediately beneath is all fairly near, you see the shadows of the second rib. And from then on, for this position, your cranial is on the right, caudal is left, and just to make sure. Okay, so as you can assess and look, and now we will slide down.
Can you
second rib, your third rib,
just bring up my cursor.
and your
Cursor.
fourth rib. Okay, so the target will be on the fourth rib, and what you'll be able to see
Your focus now
here, I'll put it center, so that's my fourth rib, that's my target. So on top will be the subcutaneous and the fat layer. And can we enhance, look for the PEC major? Can we show it on the screen? PEC major? I'll try to get a good defined line between PEC major and PEC minor.
Okay, this is PEC major. Yeah.
Okay, that's PEC major. And PEC minor, see that imaginary or the facial line, or dectopectoral line.
Yeah,
and just below that will be your PEC minor.
Yep.
And if you want to know, then serratus anterior. And that should be that the marking line. And where we will insert the for PECS 2 is between your PEC major. That'd be nice lines too. I hope to get that. Separate between the PEC minor and the serratus anterior. And also for PECS 1, we just stop there to get your PEC major and PEC minor. Okay, all right, so let's prepare. Okay, so now I've cleaned the patient. For this purpose, I'm just for our demonstration today. That's why I'm looking at some what we do is actually we cover. But here so that you can see where I place my probe and where I put the needle in. So hopefully it gives an idea of how we perform this. Nanti propofol naik sikit lah, dia punya piece naik sikit. Okay. Alright. So as for me, ergonomics is important.
2.5.
My screen, where my probe is, I'm using my right hand. My needle will be on this side. So my assistant might have to be there, but I will always keep my things here so that I'm comfortable on that part. Okay, come to start now. Okay, just to make sure I'm right. My landmark, where I am. Okay, 2, itu sini, 2, 3, 4. Okay. Okay, all right. Okay, come. Sekarang you kena, saya tak nak you cross camera. You angkatkan untuk saya? Angkatkan. Okay. Okay. Okay.
So what Dr. Mafiz did was change the needle from 100 millimeter one to 50 millimeter one for better control.
Tak nampak macam. Yeah. Satu angle lain ni. Okay. Quite far situ. My target is here.
Okay. So you can see the needle tip. Okay, this one. Not separate though. You're aiming the one below,
Yep.
Okay. It's hitting the rib, fourth rib. Try.
Split.
Okay, aspirate, nothing. Inject it.
Okay.
You can see the spread. Yeah.
Okay, boleh.
How many mils here? So there's a spread between the PECS minor and the serratus. $20 mils.
20 mils.
This is Lupivacaine.
Yep. Oh, sorry, tertarik needle. Okay.
Okay, probably in the muscle on the top.
Top of the muscle lah. Sekejap.
Okay, just like push.
Sekejap, aku ada position lain salah ni. Tak ulang dia gerak lagi kan? Okay.
Okay.
Salah plane lah. Sekejap. Split.
Yep. Okay, in the correct plane. So that's 20 mils gone into the layer between PEC minor and serratus. You want me inject a bit more?
Sikit.
Okay.
Tadi tu I think needle dia lari sikit lah.
Yes.
This is better. Kan?
Okay, you can see the spread. Capsulet and chordate. Okay, that's 25 mils.
Okay, alright. Okay, so now looking for the between PECS major and PECS minor. So what I'm doing is I'm withdrawing. Aspirate bagi sikit tak?
Aspirate.
Wait, sorry. Okay, bagi sikit tak ada.
Nothing.
Okay.
A bit more.
Bagi sikit.
Bagi sikit.
Okay, yep. So
okay, yep.
So my technique, what I do is maybe as you can see, initially I was in the PEC minor and I withdraw. I'm looking for my line, the dectopectoral fascia, and what I do is once I can see that separation, so I'll stop there and give the local anesthetic, so you get the separation between your PECS major and PECS minor. Okay, all right. Thank you.
Thank you very much.
Thank you. Okay, hello. Assalamualaikum warahmatullahi wabarakatuh, and a very still morning. Good morning to all the viewers and also my colleague in HKL. Hello. I'm sure if you realized from the start, we are in a very serious tone. I think everybody's quite stressed up. It's not quite simple to organize this, and I thank you everybody. So I think we proceed to the block that I will be performing today with the help of Dr. Shah, who will guide us through what we're going to do. So as you can see from the earlier was the PECS 2 and PECS 1. So this is the extension in terms of when they initially described for blocks for mastectomy, it was PECS 1, PECS 2 and developed SAP or the Serratus anterior plain block initially for mastectomy. And apparently they do find in terms of when they do and also evidence that giving that would help in rib fracture, interestingly. Despite the initial thingy to say that the block cover the anterolateral, but Serratus anterior apparently would be beneficial in terms of what do you call that?
Posterior.
Yeah, giving the posterior nerve block as well, and this is comfortable, especially for rib fracture. The issue here is the inability patient because to breathe because of pain. Hence, by giving this nerve block, it not nerve block, it's this plain block, this sexy block. It would be able to facilitate a smooth recovery as well as prevent atelectasis. All right. So we are in a slightly different position. I mean, you can refer this in YouTube. There are quite a number of techniques that people do. One of the advantage for this is actually patient, you can do it anteriorly, but I'm just going to show you in terms of posterior. So we do with the scout scan in identifying where, if you remember the initial
Hi,
sort of
Dr.
thingy,
Mafis.
but here careful, tangan dia tu.
Hi. I'm Mafis Sany
You
here.
can hear me,
okay. Yes. May I know what case is that?
Yes.
Rib fracture, is it?
Okay, this patient has a rib fracture 2 to 6, at the same time clavicle fracture. So he has been having this for at least 2 days. We're doing, the procedure that we're doing is the clavicle plating. But at the same time, because patient is under GA and hence did complain of pain score of while deep breathing about 5 to 6. So this is why we are giving this so that it will facilitate in terms of extubation and after that his recovery in not just in recovery but in the ward as well.
Okay.
All right. Okay.
What is
so
the
we'll sort of like.
What is the site of fractures? Rib fracture, any flail segment?
No flail segment.
No flail segment. No flail segment. No pneumothorax. Yep.
The fracture, is it which part? Posterior, posterolateral, anterolateral, or lateral part of the ribs? I mean, in terms
anterolateral.
of thorax. Anterolateral thorax. Okay.
Yes.
Okay. All right. So we'll start to look, and basically, if you remember, because this is slightly awkward in terms of, but if you remember from initially when we do the PECS 1 and PECS 2 from the clavicle, infraclavicular approach, and yeah, Dr. Shah.
This is the PECS major.
Okay. All right. So this is number 2. Yeah. So
this is the.
Wait, let me get a good view for this
May
one.
I see your site of probe location from the video? If we can, audience can see the anatomical
it's slight
site.
awkward. Okay, you can
you
see.
put the probe,
Turn
the
around.
anatomical site on the patients.
Yep.
Okay.
Okay. I'm trying very careful not to abduct too much because otherwise.
Patient in lateral position, lateral decubitus position, right? Okay.
Patient is in lateral decubitus position, correct? Yep. Okay.
Okay. Let's
so
go back to
we'll because we have to point the structures. Okay. Okay. All right. So.
Okay. This is the first rib below the clavicle. That would be the second rib. Okay, the PEC major, you see it's quite, quite thick in this gentleman. Then, yeah, the PECS minor will come into view. This is the third rib and the fourth rib, and you can see that the PECS major has actually ended. So this is the PECS minor at this point. And this is the fourth, and this is the fifth rib.
Okay, all right. So point to me the way I'm doing. So now I'm moving from the infraclavicular, coming down, show here, towards the mid-axillary line. Yeah. So we'll just move to the mid-axillary line, maintaining the rib to be. So you get your mid-axillary line. Okay.
So your probe in transverse position, yeah, Mafiz?
Yes.
Transverse, yeah, transverse scan. Okay.
Okay.
So this is your serratus, and at this point you can see that this is the lat dorsi coming into view. So Dr. Mafiz will attempt to put the needle and deposit local anesthetic at this particular plane.
Okay, all right, okay. Come, kita ready. Just wanna explain something regarding the serratus anterior before we puncture here. Okay, come.
So the reason why we actually position it this way, because it's a bit awkward, because mainly to show the actual where to put the probe. We thought of actually if the patient is in a supine position, it might be a bit more difficult for the video to capture the whole process.
But we can do in supine position, right? Usually.
Yes. You can. Definitely you can.
But this patient is a bit bulky, so it would probably a bit more, in our view, a bit more difficult for the positioning and so on, particularly for the video to actually capture where the probe is. So yeah, it is kind of awkward now for us to actually keep the patient in this position, but mainly at least the viewers can actually appreciate where the probe is and where the needle insertion is going to be.
Okay. So.
Okay. Yeah. So again, this is the serratus, and this is going to the lat dorsi. So the needle Mafi is going to approach from caudate, and hoping to actually deposit local anesthetic at this particular point.
So it will be in plane approach, right?
Yes, it will be in plane approach.
Okay.
Okay, I'm going to assist Dr. Mafiz over there. Okay.
So this patient, you're using linear probe, Mafiz?
Yep,
linear probe. Okay, we'll just wait until the needle appears better in the screen, then we'll turn.
What is the length of
screen.
needle you have
Unfortunate-
selected? Length of needle?
You're using a 50, is it?
I'm using at the moment I'm using a 100.
A 100 millimeter needle.
100
I think I can.
Okay.
I think
Yeah, I think we can use
50 lah,
50 as well.
50, 50.
Yeah,
Change 50.
Okay.
Okay,
Yeah.
Mafeitz,
Yeah.
while you
Okay.
are this one in inserting the needle, can you notice the thoracodorsal artery just now?
Yeah, I
in
was
terms-
actually trying to look for the color.
Thoracodorsal, yeah.
In that
Okay,
layer
and
and
then
move
around,
about. Yeah, this is one structure that you have to be
Can-
careful when looking at the
Oh.
layer because that's the last thing that we
Can we
wanna
get the
hit.
ultrasound
Okay.
image in view?
Okay. Punya needle.
All right, okay.
needle. Okay, yep.
Just get the needle first and lepas tu
Okay,
boleh.
okay, alright, okay. Just get the needle first. Okay. Okay, I think I'm there. Okay.
So you're in serratus already.
Off color, off color.
Okay, you can see the silhouette of the, yep.
Needles, okay.
Aspirate. Bagi sikit, sikit je.
Okay, can you see that?
Okay.
It's
Yes.
actually separating the two muscles. Yeah.
Okay. So we're giving 0.375 ropivacaine, all 20 mils.
So you're infiltrating between serratus anterior and latissimus dorsi, right? The plane in between.
Dosa, yeah. Yep,
Okay.
yep. All. Okay. Oops.
Oh,
Okay. Usually technical.
yeah.
Dia aku ni. Betul lah. Okay.
Okay.
Alright, okay. Alright. So just finishing my 20 mils. Alright.
Okay.
So this patient will proceed with the op. Alright. Okay. Okay, good.
Okay, Mafeitz,
Okay.
there's also a similar question like previous ESP, injecting anterior to serratus anterior between SA and latissimus dorsi, or injecting posterior between the ribs and the serratus anterior. Which one is a preference? Any advantage? Or
Okay, it's actually quite interesting because initially the description was giving to the we call the posterior serratus,
yes.
and traditionally the serratus anterior block was dead at that point. So that was the
Posterior to
landmark that they
serratus,
have.
Yeah.
Yes, yeah, posterior approach. That was the landmark. Then after that, with ultrasound, they sort of like they discovered that with the giving the some people call it superficial. Or the anterior approach,
Yes.
or you give the posterior, it would give a similar result.
If you put catheter, are you putting at the same plane also just now? If you plan to put SPB catheter?
Catheter will be posterior. I guess you would get a more, because the thing is, the problem with this plane block is the ability to ensure that it stays in that plane. So if you're getting between latissimus dorsi and patient movement, especially when patient has no pain, so the tendency for the tip of the catheter to go off plane is more.
Oh.
If it's below because of the muscle and how it moves with just the muscle, and after that you have your intercostal there and your ribs, practically it should stay there compared to if you put in between your the anterior layer between latissimus dorsi and serratus anterior.
Because sometimes I notice there's difficulty to position the catheter tip in between the muscle plane. Sometimes you need to hydrodissect, create
thing as
the
well.
pocket
You're right.
first,
You're
right? So, and we're not sure the
That's
tip,
right.
ultimately where is the tip
and when
placed.
Yep, and we have the pocket, and when you put the catheter, you would not really know where it goes through the plane, or the tip would actually embed in the muscle.
I see.
So that's another issue where the spread. But of course, if you give a volume, there'll be some mass volume, and that would spread somehow and absorb. So you may get a plus minus. But to get directly, I think we have to look into literature and more studies done on that to see whether that's what according to what we're talking about.
If you put catheter, what
You
is
can
the
see me
infusion
smile. I'm
rate?
smiling now because we are done.
Yeah. If you put catheter, last question, Hafiz. If you put catheter, what is the infusion rate? Infusion rate?
My infusion rate for my catheter, I
SVB
would go from maybe start from say
6 to 10.
8 to 12 mils per hour. But then it depends as well. As you know, if it's a superficial, but for Serratus, yeah, that would be my rate, 8 to 10.
Okay.
Because if it's more superficial, sometimes what can happen, because this is a plane, so you may get the complaints from your APS nurse or from the ward that the whole area is like wet, especially if it's superficial. But
see.
for say for example, for my patient, if I had put catheter, I would be comfortable and to give on that infusion rate.
Okay. I think is that all from Gleneagles
Yep, I
Medini?
think
Yeah.
I'm laughing and I'm smiling. So yeah, I'm happy that we're done with this. All right. So I think we proceed to the next session.
Okay. Thank you very much, team over there.
All right. Thank you. Okay. Selamat Malaysia.
Okay, thank you for the live demo session from JB to Dr. Shahridan Fathil and also Dr. Mafeitzeral. Okay, I think we will synchronize and on air for the live panel discussions with the team from JB as well as HKL facilitators which are already with me here. Okay, JB. Are you ready? Can you see us? We can see you.
Yes, yes. Loud and clear.
Good. Okay, we proceed with the questions. Can we have the questions? First questions. What is the first choice of block among various techniques available for mastectomy? For example, paravertebral, PECS1 and PECS2. Maybe JB team can answer. Dr. Mafiz?
I'll answer that. I think in terms of evidence for acute pain, the PECS, which include PECS1 and PECS2 injection, is superior for acute pain compared to paravertebral. But I think there's some evidence to suggest that paravertebral is better for chronic pain, chronic post-surgical pain syndrome. Personally, from the logistics point of view, I would still prefer to do the PECS in combination with the rest of the other ERAS techniques. So my first choice will be the PECS block for mastectomy.
I believe HKL team also will be the same, or you have any preference?
My answer for this question is always consistent. Do blocks that what is good in your hands. I mean, if you are very good in PECS block, go ahead. And if you are the bold group and to attempt the paravertebral block, yeah, please go ahead as well. But for mastectomy, if you understand if only mastectomy without axillary clearance, probably PECS, paravertebral and PECS2 block won't make much difference. But if there's an axillary clearance, I would prefer do a PECS2 block because of the element of blockade from the brachial plexus, the thoracodorsal, serratus, the long thoracic nerve for the axillary clearance procedure.
Okay, just something to add as well. During the anatomy discussion just now, it was just focusing on the chest wall techniques. But don't forget that regarding the innervation of the scapula and the surrounding muscles, and also the breast and the surrounding tissues, you also have to consider their innervation is actually from the brachial plexus. So I would agree with Dr. Amir and both also Dr. Shah. Probably the technique of choice, considering all the anatomical considerations, would be whichever that is best in your hands, but do what is the safest option first. So I guess with that in respect, I think with multimodal PECS2 technique will be appropriate.
Okay, next question. Having an local anesthetic bubble just on top of your CT junction is an indigenous virtual marker, and what is your usual practice? Okay, this is quite technical
What's
question.
a CT junction?
Coastal transverse junction. I also know what the CT stands for.
I reckon this question is for me. Uh, I've no intention to create a bubble of air pocket at the close to the coastal transverse junction. Is actually unintentional, but in case when we show the sono anatomy, people wonders what is that white hyperechoic dot on that screen. So I just want to clarify that's the bubble, air bubble that I unintentionally have injected during the procedure.
Okay, I think next question. For mastectomy and axillary clearance, is thoracic erector spinal plane alone adequate? And do you perform additional interfacial techniques? Maybe HKL team, yeah.
HKL team.
Yeah, I'm sure HKL has a lot of the mastectomy list, and perhaps from your experience that you can share with all of us.
Okay. There are evidence to say that thoracic ESP alone is adequate. But actually, it goes back to the basic principles of are you in the correct plane or not. So there are cadaveric studies saying that ESP, thoracic ESP can actually spread up to C3, and in that sense, it blocks the brachial plexus and hence should be able to cover for mastectomy and axillary clearance. So if you are in that group, then I would probably say yes, it is adequate. But again, it goes back to the spread and where you are actually within the fascia. I think that is actually needs further practice, and I think to know that you are in the correct plane is something that is not that easy. So it is actually depends on whether you are in the correct plane or not. But per se, then I would say yes.
I would like to add, I think this depends on the patient as well, and patient size, patient muscle layer, and sometimes I guess because what is good about all this technique is you have option and choice. All right, if it's difficult to identify your plane because of the sort of like a white fatty appearance with small or thin muscle layers, which you would not too convinced on where you want to do that, then perhaps you go for your posterior, but otherwise also anterior. Again, adding on to the earlier question of paravertebral or the plane blocks, again, the depends on the recent, again, patient factor as well. And good to have this option so you can decide, because at the end of the day, what is important is not what we do, but for the patient.
Okay, Mafis, thank you. Next question. Can we use twin needle for catheter insertion in ESP block in resource limited center? For example, they don't have appropriate block needle with catheter. Okay, Amir.
Yes, I agree with you. When we first started, Tohi needle is the only choice that we have. But the drawback of using Tohi needle is actually this is a needle. I mean, needle over catheter. After you have removed the needle, you already created a large space where after when you run the infusion, it will start leaking. And the surrounding area will be wet, and the catheter it can be easily displaced. What you can do if you have glue, you can always seal around the catheter
insertion site.
Yeah, insertion site.
Okay. So preferably to use appropriate block catheter, block needles with catheter. Okay. Well, next question. What are the optimum volume and concentration of local anesthetic drugs for bilateral ESP block at T3 and T4 level? Dr. Azrin?
Okay, depending on the indication for the case, I think the first choice for anything bilateral should be epidural. But again, if you are balancing the risk and benefit, and of course the ESP is a more peripheral technique and is safer with less complications, with similar effects, I would add. So basically, volume and concentration of LA drugs. Again, ESP is actually interfacial plane block, and volume needs to be is considered here. So I guess overall you can actually have a same mass by adjusting volume and concentration. So what we do here usually is we still fix the volume, roughly about 20 to 30 mils, but concentration we can actually bring down from 0.375 to even 0.2% ropivacaine.
Okay. Next question. Does local anesthetic volume injected lost in the midst of surgical plane dissection and subsequently affects its efficacy block, which is done preoperatively, especially in conjunction with axillary and lymph node dissections? This issue of leakage from the plane. Maybe we give to JV. Anyone of you?
In some of the cases where I've done these blocks, and the surgeons can actually tell me exactly, and some are concerned about the actual LA disrupting their plane of surgery and things like that. So I do understand where they're coming from. Especially, and also if you are actually not injecting in a particular plane, you accidentally inject in one of the muscle layers, what happens that the surgeon also can actually tell you that you have actually done a bit more traumatic block. So, but from experience, if you are in the correct plane, even though with the surgery there's going to be exposure and things like that, there is to a certain degree some absorption into the nerves prior to the surgical plane dissection, and most of the time, if you're in the correct plane, the block will actually work. The issue is that if you're not in the correct plane, where you inject in the sub epimysium, within the muscle, that is where probably the block will not be as effective as it should be.
Okay, next question. Can the Serratus anterior block used instead of ESP block for rib fractures?
Yep, definitely it can. I think compared to ESP and Serratus anterior is in a way safer because of its, I mean, we're talking about the superficial or the anterior technique of Serratus anterior block. And you can use, it depends as well. If the rib fracture is on your, for example, like what I did today, because the fracture is on the more towards the anterior. Yeah, that's right. If it's there, you have your rib fracture there, it's almost impossible to put your needle there. So that's why as well, it's an option. So where you can get, you can do the ESP block for rib fracture. Both has its advantages, and of course, it's indication on what type of where the rib fractures are as well, because where the point you want to put. Because one of the issue that can happen as well as rib fracture causing pneumothorax, and in the emergency department, they put it in a chest tube as an emergency measure. But of course, the rib fracture is still there, and this is where maybe you would prefer to do a ESP because it's further away from the chest tube. So usually they put about T4, T5,
okay. Some surgeons give one dose of thromboprophylaxis for ERAS protocol. Is it safe, for example, to give epidural after that? Shah?
I think it's about timing. So that's why you need to communicate with the surgeons as well, particularly if you're planning a epidural. So I think in general, if the surgeons do give a pre-operative dose the night before, so it's like, as a general rule for the low molecular weight, it's 12 hours. So, if you're doing a case at 8, so probably, the 6 p.m. should be the actual timing of the dose preoperatively. So it's still important that you time the dose well as actually removal. If the patients are on regular post-operative DVT prophylaxis, when you move the epidurals is so important. So that so again, I think when we talk about enhanced recovery, there's a lot of this communication between the surgeons and anesthetists. So technically, we have some role, but the surgeons also have, I think, a bigger role pre-op and post-op. So communication is important. So to answer whether it's safe, it's all about timing.
Yep. I mean, by ERAS definition itself is multidisciplinary. So, and in the recommendation of ERAS for certain, I mean, we're talking ERAS as a whole, surgery, epidural is one of the mainstay for ERAS protocol. So, while doing it again, communication would be the key to ensure that we do not cause issues or unprecedented problems for the patient.
So I think the safety precaution applies in both epidural and plain block in terms of interval to serve thromboprophylaxis prior to surgery. Okay, next question. Can erector spinae block cover upper abdominal surgery like cholecystectomy? Okay, Amir?
I presume this is for analgesia because I don't think if it's open, if you do, I'm not sure. I mean, maybe it's possible to do
issue with visceral cover with erector spinae block, but I think this is for more of analgesia and post-op analgesia.
Yeah, analgesia, yes. I would say yes. Sometimes I do, especially for patient who's planned for laparoscopic, then KIV open and we end up have open. You don't really give prophylactic blocks or pre. So you give that post-op for, what do you call that, for analgesia. HKL?
I think in choosing the level of the erector spinae plain block, you have to understand where the surgeons put the ports or incision. So instead of T4 transverse process that I did just now, probably you can go lower at probably T6 or T7. So the principles apply. I mean, you have to tailor to the surgical incision that affect the dermatome level.
Just something to add. If you remember when Dr. Amir performed the ESP just now, it was at a high thoracic level, and you can actually see 3 layers of muscles. You have trapezius, rhomboid, and erector spinae. So it is also said that if you want to perform to cover lower dermatome levels, you should see only 2 layers of muscle. So at the point where you see 2 layers of muscle, then you are actually covering for the upper abdomen surgery at least as well. So what you need to see is do the same scans, but you need to only see 2 layers of muscles rather than 3.
Okay, this will be the last question. Do you add clonidine, adrenaline, or dexmedetomidine into the blocks? Yeah. Any taken block?
Mafeitzeral.
Clonidine, we don't have in Malaysia. So I've never had that for my, even for my spinal in Malaysia. Adrenaline, do you add? Okay, this is personal. No, I don't. Dexmedetomidine, yeah, there are few recommendation, or not recommendation, sorry, that would be not the correct word, the practice where you have that bit in terms of prolonging the duration of block. But for me, no, I don't. Mine is mostly pure, local anesthetic.
I think we practice the same in HKL. We don't add any adjuvant in our blocks.
Okay.
Perhaps the only adjuvant that we add for our block would be an IV dexamethasone.
Steroids.
4 milligram.
Okay.
Yeah.
Steroid, yeah.
4 to 8 milligrams that enhance the duration of action.
Okay. And it's quite safe also. So I think with that, I would like to end this panel discussion. I'd like to thanks to all 4 facilitators from both Hospital Kuala Lumpur and also Gleneagles Medini hospitals. So again, I believe for those who haven't scanned the QR code on top, I think on the screen, okay, please use your MMA app. So hopefully this workshop had fruitfully educated and benefit the audience with some knowledge and technical skill with relevant to anterior and posterior chest wall blocks. Once again, I would like to thank all facilitators from College of Anesthesiologists, Academy of Medicine Malaysia, And ASPEN Malaysia for taking an effort to materialize this educational resourceful activity. Thanks to the audience for patiently be with us for the last 2 hours, and apologize for any technical glitches which we encountered during the session. And I really appreciate the support from technical and AV team as well. So don't forget to claim your CPD point using MMA application and scan QR code on the screen. I'm ending this with quote from Danny and Harold Griffiths from VJA 2005. Regional anesthesia always works, provided you put the right dose of the right drug in the right place. Till we meet again in the future. Thank you.
Thank you.
Bye.